Well, welcome everybody to another VITA Learning webinar. Today we have the esteemed Mr. Peter Pizzi to talk about what he does best, which is everything lab related, clinical related. Peter's got such a great depth of information that he really helps all of us out, in which we have recorded some past videos, webinars with Peter, and so forth. Today, Peter's going to join us and is going to talk about the pink and white porcelain. So, Peter, hi. Wave to everyone. You're on candid camera.
Sounds good.
So, so we will get going. Just a couple things, though, at first. I just want to remind everyone that if you've done this before with us on the VITA Learning webinars, your phone is on mute. And that panel that pops out on the right-hand side of your screen, you'll find there's a question section there. Just pop that out. And if you have a question, go ahead and type in, send it to us. And at the end of the program, we will go over all those questions that you may have. We will also be recording this video as always, this webinar. It will be posted, and give us a couple days, it'll be posted on our VITA North America YouTube channel, along with all the other social media accounts. So please visit us if you want to revisit Mr. Peter Pizzi on this topic. So Peter, if some of you don't know, he owns his own lab. It's called Pizzi Dental Studio out in Staten Island, New York. He's been a technician since 1984, has a CDT and MDT. I don't even know who does Master Dental Technician a curriculum in the U.S. anymore. Do you know? Does anybody do that anymore?
Yeah, so actually there's a program that I'm trying to restart, which I just haven't had time for, but there will be a new master's program based out of New York, and I'm going to try to make it across the country at some point.
Excellent. That's good. That's good to hear.
And I was one of the educators in it, so I've been involved in it for years.
Excellent. It's always good to hear. Everybody wants to continue to grow in this field for sure. And then he has personal appreciation and expertise on all phases of traditional and digital dental technology and photography. The good thing about Peter is, as most know, Peter deals a lot with the clinical aspect as well. So he sees his start to finish. He really gives us the opportunity to look at the entire case, how it reacts, how it works, what the outcome is. And that's how I assume, Peter, you've learned most of what you've learned is by following through your cases and see what the end result is, right?
Yeah, I mean, that's the key, right? To have both eyes, to see both sides, I think is kind of the key for us and the viability in the future.
So Peter's a member of the American Academy of Aesthetic Dentistry, which isn't easy to become as a laboratory technician. He's a graduate, recognized specialist and mentor of the Coyce Center for Dental Excellence. He's co-editor-in-chief of Inside Dental Technology. So Peter, I will go ahead and leave this up to you. And so I will turn you into the presenter, and you now have control of the screen. So here is Mr. Peter Pizzi.
I'm just waiting for the, oh, here it comes. Thanks, Jim.
It's a quick throw off, handoff,
Gotcha.
I guess.
Okay,
Sometimes.
Thank you so much, Jim. Appreciate it. Welcome, everybody, and welcome to another, what I would say, interesting topic. And kudos to my friend Jim, because I think a lot of the topics that you guys are hearing came from your suggestions, and then Jim kind of really packaged them together and tasked me with fulfilling them, which was kind of fun, to be honest with you, because it's nice to take it from a different perspective, not just say what I want to say. So this has actually worked out fairly well, I think. Purpose of today is really about talking more about the pink and white, and I wanted to break it down a little bit differently than maybe you guys are probably used to. And what I mean by that is, obviously I'm going to talk about pink ceramics and the importance of using pink ceramics and how it works for us. But I think there's so much more to it than just that. So first, let me tell you, to be clear, that in dentistry today, about 70% of dentistry, at least profit-wise, financially, is made from implants. So that means to me that if I go through labs around this country, and I've been traveling a lot again, so it's nice to kind of see people and be in labs. If I don't see the labs in the 30, 40, 50 percentile of implant work, that usually means to me that there's a market that you're not hitting. And that's important, because that is a very important market thing. There's a lot of implants being placed. If you walk into my lab behind me, you'll find that the number is really accurate to the average. And what I mean by that is probably about 7 out of the 10 pans at any given point on in my desk or my laboratory have maybe 1 implant in them, or is a full mouth of implants. So there's a lot of implants here involved. And look, pink and white isn't just about implants. I don't want to make it that way, but the reason I brought it in is because once you have more implants, you tend to have more pink restorative. And that's why it's important that you start to understand how that pink is affected, not only by the implant itself, but also by how we design the white part of the restoration. So for those of you who know me, I think you know the phrase face white and pink. I use it so often. And I think now we have the opportunity to dive into that a little bit more than usual. I'm doing lots of pink cases. Probably about 25 or 30% of my cases now have some sort of pink ceramic on them. Behind me on my desk, I have a window veneer that I'm also putting pink on the veneer. So it's kind of a lot of different areas of pink that I probably never imagined 5, 10 years ago I would be doing. I also do a lot of my pink at the end of my cases, and I'll kind of touch on this a little bit more as we go through the cases today. But I don't build the pink exactly the same way as I'm building the whole case. I kind of try to build the bases for the pinks, and then utilize that at the end in my glaze bake, usually in lower fusing or lowering the fusing temperatures of the materials to allow me to put more of this in at the very end of the case. But I wanted to kind of look at this a little bit differently, not just about the pink buildup, although I will obviously break that down. For those of you who know me, you've heard me say 1 billion times face white, pink, and person. Today we're going to dive into really the face white and pink and how important it really is for us to look at this from a different perspective. So let's first start with the face, and that's really about the lip dynamics for us. Everybody has a different lip dynamic, and it's important that you understand that each lip dynamic presents different challenges for us. You're going to find that some patients do what we call show a lot of pink, right? Those are the kind of people who are the dolichofacial. They have this long kind of pink or a very high lip display. We call it vertical maxillary excess. And the challenge with these patients are, because they show so much, your restorative has to be that much better. The harmony between the white and the pink has to be better, and the light transmission between these two materials has to be better. Good news though is I always tell people only about 15% of the population is that dolichofacial, so it makes life a little bit easier for you. But they're out there, and we work on them lots. Lots of our cases, obviously 15% of them are there. The brachiofacial, I'm kind of brachiofacial. These are the people who don't really show much teeth. And I always joke and used to say years ago that these are the people that we love doing single centrals on, right? Because you put the single central in the patient's mouth and they smile and go, yeah, it looks great, doc, thank you. But you don't see it, you don't know it, and they don't really show much tooth structure. So those are actually great patients for us because they're not usually as picky. The flaw with that is also only about 15% of our market share. So those are the kind of two extremes, the patients who show lots of white and pink and the patients who don't show much white and pink. And the normal, which is about 70% of our world today, is what we call the mesiofacial people. And those are the average, and they basically either show 0 to 4 millimeters of white, sometimes a little bit of pink or papilla. So those are kind of where we work in the scope of it. And I think the average, obviously, is that mesiofacial patient where we're actually seeing some teeth. But when you see teeth, the more teeth you see, you tend to see some pinks, papilla peaks, and a little bit of harmony that harmonize over the tooth. So I wanted to kind of focus on that a little bit. One of the challenges that we tend to have is we do focus a lot on this, what you see here, right? As ceramists, and I'm assuming most of you are ceramists out there, we're always working on all the little details, the effects of our translucencies, what kind of enamel we're going to use, what the surface topography and all those details look like. But even in this picture, as I'm focusing on the white or the incisal edge, what do you notice? You really start to notice right away how that little bit of pink has an influence on what we see. And I got to be honest, there are a lot of times I do cases and I talk to the doctors and say, you know, I understand that this is not really a pink and white case, but they need a little pink. And it might just be me putting a papilla somewhere. I've done many cases where they're basically just all my white teeth with papillas, no actual gingival work, just the papillas to create the separation and the individuality of the teeth and not make the contact look super, super long. So that little bit of pink in there really is helpful for nature to make things look real. And as I drop that down or raise the lip, right, because the lip can go up a little bit, you see much more. And the more you see, you'll notice that the health of that pink, the light transmission, the optics of it is really important for us. So you should also notice that the pink is not the same, the coloration on the pink. It's definitely darker on the interproximals. You can see it lightens up a little bit between the 8 and 9. That's kind of different on every case. It really depends on the type of tissue that we're dealing with. But you start to see that each of these, and you can also start to see a little bit of surface topography in there, some little texture. So I'll drop that down even more and now really look at that pink and say, okay, wow, look at the little details that are in there. Look at the brightness where the root and the emergence start to come from, or where the zenith is, tends to be a little bit on the brighter side. And look at all the little dark striations and colorations that run through that, depending on several aspects of the tissue. So this is really critical for us because realistically, forgetting the pink for a second, when we're designing nature, when we're emulating tooth and form, what you're really looking for is to follow what nature has done for you. And that really comes from looking at the roots and the emergence profiles of the teeth. So as I'm following my heights of contour and the line angles of those teeth, I'm really trying to make sure I understand not only what the shape and form of the tooth looks like, but what the emergence profile and the gingival aspect of the tooth looks like, where I want my zenith, how much pressure I want to put on the tissue. Do I want to push the tissue up and out? Do I want to let the tissue kind of fall and grow down? And how much do I want to support my papilla tissue? So each of those becomes really critical aspects in the lip dynamic concept. Another thing that you guys probably heard me talk about over the years, and more recently, I think I've been putting this in some lectures, is the types of materials we use. And this is not a materials lecture, so I don't really want to go too far into that. I just wanted to kind of clarify, though, a few more things. I've been saying a lot lately, and I just said this in New Orleans this weekend, that these materials here, this top group of materials here, is where I think I want to work as much as possible. Now, that doesn't mean that I don't want to do monolithic restorations. I do plenty of them. It doesn't mean that I don't want to micro layer. I do plenty of micro layering. I do them all. But these are the areas where I want to do the most amount of work. And the reason for this is because working with feldspathics, window veneers, or fully layered restorations usually gives me the most differential in my business as compared to what's happening throughout our entire profession. I think that's a key point. So my argument would be is this area that I just highlighted is where our profession tends to spend the most of its time. There's nothing wrong with working in these areas. I don't want to make it like these are bad things. I do all of these processes, but I can tell you the phone calls that I get from doctors all around the world are asking me about these things. Do you still do feldspathic veneers? Do you do window veneers? Do you fully layer restorations? And I want to be clear because I know what happens when I bring this up in the technician world. The dilemma right now is we're all looking for more technicians. Everybody's saying we can't find good help. Nobody's a ceramist anymore. Nobody layers anymore. I get that, partially true. But I'd also argue that a lot of people never built up a crown on a CAD system with a mouse before until you taught them, right? Most of the newer people that come into our profession, you're teaching them. So it's really what we teach them that's going to evolve where we go and where we grow to. And I'm going to tell you, for me, our viability is in this area. Now, once we're in this area, then obviously the pink part becomes even more critical, because now we're talking about more dealing with the optics of light and the restorative factor that I already told you is probably in the 25 percentile of working with pink material. So that pink restorative part kind of ties the two of them together a little bit, and I just wanted to throw that out there for you guys. All right, so we talked a little bit about the lip dynamic. Let's talk about how the white actually now supports the pink. And what I mean by that is there are three basic types of tissue. We call them tissue biotypes. And you and us as technicians need to have this in our vocabulary and have a good resolve in how we speak about this part of the process, because this is what makes us better. It also makes us understand what to do differently to be successful in our cases. So let me explain the basic biotypes of tissue. We basically have what we call Bio 1. Bio 1 tends to be very thin tissue, tends to be very short and thin, and you can almost see through it. And it's usually very low or on the tooth, where you can actually see a lot of the tooth exposure and see the coloration of the root behind it. Bio 2 tissue is a little bit thicker, so you actually get a little more resiliency in the tissue. It's actually thicker, so it allows a little less light to penetrate through it, which means you mask a little bit more of the root and the CEJ and the emergence. And then there is Bio 3. And the Bio 3 tissue is the thickest of the tissues. It's usually coming up higher over the restoration of the tooth itself, and there's enough thickness into it that it almost doesn't matter what's behind it as much. So those three tissue types are really important for us to think through when we're thinking through what the restoration is. And again, I'm on the technician side here, so I know a lot of you, as I'm saying that, are saying, well, how do we know? The doctors don't tell us, it's the doctor's fault. Let's skip all that. Your job is to know. And if you know, you can manage your way through your cases better. So let me give you a few little tips in how I work through this. One, it should be fairly easy to look at the cast and see the type of tissue. You could tell pretty quickly just looking at the cast if there's thin tissue or thick tissue. You may not be able to be specific, it's 1, 2, or 3, but you can definitely tell the difference between 1 and 3 very easily. And as I'm looking at the tissue, like this patient here, you can see that this tissue is fairly nice. It's at least a Bio 2, if not a Bio 3, just from the look of it. You can see it's not thin, washy, kind of papery tissue. So my job becomes to be able to support that tissue with my restorative. So when I'm placing either a veneer or a full crown on there, I want that crown or that restoration to harmonize with the gingival tissue and do what it would do in nature, which is what? Support the papilla, put pressure on where the zenith should be. You get that little bit of a lighter kind of a push on the tissue, and then again, be able to support the papillas interproximally. So even in the white, I'm always thinking of the tissue part of the restoration. And as I work my way through cases, and I'll work my way through this one quick, it's kind of an old case, but this patient is Lara. She came to myself and Dr. Michael about 10, 12 years ago now. It's an old case. And I won't bore you with all the details of the case. You can see the cuspid is sticking way out of the arch. So orthodontics was a kind of a priority for us. Also, you guys probably don't notice, but that number 11, the cuspid there is not a real tooth. It's a baby tooth, a deciduous tooth, and that's going to have to come out. So it's going to change how we restore her. But also look at her tissue. You should be able to look at this right away and say, you know, this is definitely not Bio 3. It's probably 2, maybe even in the 1 family, because it's a thinner tissue type, and that's going to make the restorative a little more challenging for us. So I can tell you that we did some orthodontics, we moved the tooth in place, we actually brought the implant into the site that we'd like, and we did aesthetic evaluation to figure out where the incisal edge should be, and this was just done with some basic composites after we worked through the functional challenges with our patient. But here's what I did as soon as I got the case. Again, this is 10, 12 years ago, so the communication was different. I knew I wanted to make an abutment. I had to figure out what type of an abutment I wanted to make, metal, zirconia, lithium disilicate. And I also had to figure out what that abutment would be either useful or non-useful to me from the aesthetic point of view. So what did I do? I actually took the soft tissue cast that I had, I took the flashing off my camera and put it behind the cast, and then I took the picture in front of the cast. And what that allowed me to do was actually see the thickness of the tissue. And right away, you should be able to look at this and say, you know what? That's Bio 1. That's super thin tissue. So that means if I really want to make a metal abutment, I'm going to have a gray hue that's going to float underneath that gingival the whole time, and I don't really want that to happen. Now, some of you might have caught, and I'm going to go back one slide and say, you know, the patient looks like they're brachiofacial. So this means that they don't show a lot of gum. Do I even have to worry about that? And I would argue I want to do the right thing no matter what the situation is. So in my case, yes, brachiofacial means that it doesn't show as much, a heavier lip dynamic. Sounds good, but I still want to manage through all the processes. And for me, I know that I have a problem here now with my abutment because this is going to look great for me. So I could switch that to a different material, which I didn't want to do because actually I like the metal abutment, especially in a cuspid position. So what I wound up doing was actually cutting the abutment back, hollowing this out a little bit, and adding ceramic margin material. Ceramic margin material is highly fluorescent, so it gave me a great light index, so it helped me to refract and reflect the light, which is what I wanted to do. And then it becomes my job just to create the emergence profile that's going to support the pink and white that we keep talking about. I also make the argument that as I go through the labs around the world, and not just here in the US, we tend to not understand emergence profile as well as we should. If you look at these three teeth cut off at the cervical line, notice the shapes. None of them are round. Each of them have their own kind of boxy kind of shape or tadpoleish kind of shape, or they're a little longer and skinny, or a slight weird kind of an oval shape. And that's really important for us to create emergence profiles to understand the shaping of the emergence profile that we're working with. You know, we tend to look at the teeth from the incisal edge or the facial point of view, but the more I cut that tooth down, the more the shape changes. So this is the same tooth. This is a lateral incisal edge position. That's the middle third of the lateral, and that's the gingival emergence of the lateral. And there are really three different objects that we need to understand how to work through to create the form. The other thing we need to understand in implant world is our margin placement. You want your margin placement never more than 0.5 tenths of a millimeter below the gingiva. Anything more than that, you can call it as cement fatigue, or actually the cement attaching itself to the bone, and that can cause implant loss. I always tell people that's the #1 cause of implant failure, is the cementing process. So our job is to make sure we manage the tissue and the placement if you're cementing. Today, I would much rather screw retain when I can, and I'll walk you through a few cases like that in a minute. In the end, I wound up making, I think, 5 veneers on this case, and then a metal ceramic abutment with margin material, and a metal ceramic crown also with margin material. So what that's going to give me is better optics for my restoration. And you can see here now that under my Bio 1, my very thin tissue there, what you'll notice is that thinness of the tissue is actually covered, or behind it has ceramic behind it. So it actually makes life a lot better for us. And then the margin itself in ceramic 360 allows me to kind of bring that ceramic up and get a better optical point for my light transmission. When I put that in the mouth, I always like to say, well, it's an old case, maybe not one of my favorite cases, but here's the good part of it. These are all veneers. Look at the pink and white transition, veneer, 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 veneer. And over here is a metal implant abutment. And you should notice that the harmony of the tissue looks pretty good. This stuff should be the easy stuff for us at this point in life. But this is, to me, where the real challenges are that we're really trying to work through, and making sure that we can make those two things harmonize well together. So in the end, the case worked out fairly well. But here was the catch for this. She wasn't a brachiofacial patient. She was a VME patient. She was a high smile patient. She just had what we call the controlled lip dynamic, or a controlled smile. So doing the right thing is always the right thing to do. You can never go wrong if you do the right thing. And in the end, without that, we would have been remaking this case, because we would have had that gray hue and that gray harmony. We wouldn't have managed the pink so well. Okay, part 2. The pink now supports the face. So not only does the white support the pink, but the pink is also our bony architecture underneath it, and that actually is supportive of the face. So again, another old case, but this one fit well for our topic today. This is Randy, and it's a case that I used to show a lot years ago. I don't think I've shown it in 4 or 5 years now, but it kind of worked when I was building this the last night or two, going through this lecture. about how I wanted it to be and what it should be. So I'm going to ignore all the other things that we went through with this case, and some of those are the occlusal factors and the aesthetic position and the plane. And I just want to focus on the face a little bit. I think you guys can tell right away that, yeah, of course the plane is off and the angulation is bad here. But you should also notice that look at the facial feature and look at the heavy collapse that the patient has on the right side of his face. And that's more challenging for us because that says to me that the bony architecture is not supportive enough, or is actually not holding up the tissue of the lip the way it's supposed to. So besides for all the other issues, that's something else to deal with. As you retract him, you can kind of see that, right? You can see he has some bony architecture support on his left side, but on the right side, he's had a loss of bone, and that's something that should have been addressed or should be addressed in the restorative. I would also argue, just for the sake of it, even though it's a different topic, I always say, Jim, we need to have an occlusal lecture. I don't know if we organize one of them. Maybe we do at the end. I don't know. If we don't, that's one to add on for the next series. But this is really a functional case. That was really more of the problem. Somebody built up its restorations, had no idea that the patient was actually what we would call a constricted envelope, meaning that they hit hard on the anterior teeth and then they grind into the back teeth. The patient did not grind that away. The doctor actually ground that away. But I could see that little dot there, and that's where the patient's really hitting. Because they're hitting there, that means the envelope is slightly constricted. So again, I won't turn this into an occlusion lecture, but I'll tell you that I want our patients to function in a normal position. I don't want them to be dysfunctional or constricted. And the constricted envelopes are usually the most dangerous envelopes for us functionally. So without going too far into that, we're going to transfer the information. We use a horizontal plane reference for that. What am I doing? I want to get the horizontal reference of what the teeth look like in the patient's face. So yes, it's a face bow, but it's really more of a facial analyzer that I'm using for this. I'm also making sure that the face is divided up properly. I don't want the interpupillary line to be my reference. I want the head being straight to be my reference. Once I have that, all the doctor needs to do is actually send me this little table, and I can mount that on my articulator, set up the cast, and I can evaluate now if the transfer is proper. So I'll do that on an instrument or an articulator. Excuse me, I've been talking a lot for the last few days, so my voice is on its way out already. I could also do this digitally, right? So what do I mean by that is, not only can I use that horizontal reference on any articulator today, but I could also use it in digital world. We have that flat platform in the AG system, or any of the milling systems that you're using should have some sort of reference to that. So we'll start to make our mount. I'm using my Panadent table as my reference. And here's what I'm really looking for at this point. Did I get the plane equal or level to what I see in the patient's mouth? I'm also going to use what I call a palatal transfer. I don't want to go too far into this today because this is not an occlusal lecture, but basically what I'm doing is I'm taking a palatal index from study model to counter model, using the palate of the cast to help me transfer. This way I don't have to worry about if the doctor took a proper bite registration, especially when they don't have teeth to work from. So the palatal index becomes really useful for me, and I'll transfer my models that way. Again, topic for another day. So here is our plane. You can see how awkward it looks. I've checked that to the table, so I could tell that my mounting now is correct. So now it's easy for me to start to figure out the occlusal plane and start to deal with the challenges. The challenges here, pink. I needed to add some pink into this to go over the tissue. I don't love going over tissue because that does kind of create food traps. And you have to be very leery of that. I'll talk about that in the last case. But in the end, I needed support. So the support is going to be that we utilize the pink. That gets tried in the patient's mouth. And when we tried it in, I remember the doctor felt like we needed more. We didn't have enough. And he was going to send the wax up back to me. And I said, you know what? Don't send it back to me. You have the patient right then and there in front of you. Put some more pink on. So he mixed up a little acrylic, added some more acrylic around the area, and we tried to get some better support out of the lip to bring that lip out and forward and support the facial harmony. I then did my framework. This was an old case, so I built up the white. I built up some of the pink. We actually tried to frame it at this point, to be honest with you. We really only tried it in because we forgot to take pink shade references. So it was kind of let's try it in and see where the pink is and see where we're going and make sure everything looks good. And then I finalized the case as a metal ceramic case, old school, with pink ceramic support on it. And this is going to get placed in the patient's mouth. You'll see a little bit of pressure on the tissue in the areas we want, and the joining of the two materials, the ceramic and the pink, on insertion. And within a day or two, that starts to harmonize a little bit better, and the coloration starts to blend in, and the blanching of the tissue goes away. And now we're getting that facial support for the patient. So look at the before and the after. Again, we've straightened the plane. That's easy. But what you should be looking at is here, in this little area here, where the harmony is off on the gingival aspect. And I wanted to support that with our new restorative process. So there's our final case. He was a happy patient, and this case, again, probably about 10, maybe even 12 years ago at this point, but I think it worked, and it did what we needed to do. And this is why I wanted to kind of twist the direction of this lecture a little bit and make you guys think it's not just about building the pink. That's just one part of it. It's how we support the pink from the white side and how the pink supports the face from the facial feature side. So doing all that for our patients is kind of what makes them happy and really makes our work the best. The third part of this to me was the hygienic part. So I said to you that on this case, what I didn't really like about this particular case was having to do more of an overlap on the tissue. And that's problematic because it's harder to clean. The patient has to use a floss threader or a water pick or something to clean in there because food and debris can get caught. So we really don't want to do that when we don't have to. But in some scenarios, we kind of have no choice. In a scenario like this, it becomes even more challenging because if you look at this patient, she has all the hardest parts about what we do kind of summed up in one case. What do I mean by that? One, I got to basically redo a 3-unit bridge here. That means I have to match a single central, right? So that's challenging enough on its own. Also, she's VME. She shows lots of pink, and she's got a pink deficiency. Now, I want to be clear, if I'm speaking to clinicians, I don't know if there are any doctors here today, some of the doctors and surgeons probably look at this and say, we can fix that. We could do bone augmentation, we could add tissue grafts. And the truth of it is, yes, we can. The challenge is can we guarantee it? And the answer is no. We don't always know that the bone augmentations will take or the tissue augmentations will take, or we don't know how many times it may take for that to happen. So, very similar to us when we're working on a difficult patient and we're working with shade and the case has to go back and forth 2-3 times, we all get frustrated. Well, this is no different when the patient goes into the doctor and they do a surgical procedure and 6 months later it's not much better and we have to do another surgical procedure and then another surgical procedure. The patient starts to lose their drive about how they want to do it, and a lot of the restorative now becomes our part, how we manage it with the white and pink. So I'm not saying this couldn't have been fixed from a surgical option. Of course it can. The patient had one, I believe, and was unhappy after that it didn't take as well as she would have liked, and now it became our job to restore it. So again, VME, single central match, and trying to fill in that pink in that tissue. Probably not a more challenging case in the world that I think I could do these days, trying to put all those little details together. So here's the way it started off. Patient was provisionalized, and we're trying to figure out where the gingival height should be. Obviously, the tissue height on the number 10 was pretty low, so we wanted to try to get it down there as much as possible, but the deficiency is also pretty big. So how far up we go and how much we bring is challenging. And part of the problem was when we initially looked at this case, the patient presented with just pink on this one tooth on the lateral. And to be honest with you, both the doctor and I kind of didn't catch on, I think, for a little while. I think I caught it after we did a bisque try-in, and I looked at it and I'm like, why are we treating this like the lateral needs pink? The cuspid needs pink, and the central needs pink. They all need pink. And we got so focused on filling the space that we kind of stopped looking at the bigger picture. The bigger picture was we needed more. So the communication and the photography was great. This is actually Dr. Miles Cohen out in Maine. Miles takes fabulous pictures, great preps across the board. And you can see that we took the information, the face, the white, and the pink, and started making some choices of what we wanted to do. We knew we were going to treat it with a zirconia bridge. This is a white ST, the VITA zirconia material. And I'm going to show you how I would normally treat my zirconia, but I sent this back to the doctor to try in just to make sure we don't have any frame issues before I start building porcelain on it, that our scan and our mill and everything worked out perfectly and everything seated the way we wanted to. Once we had that, I usually start these cases with either a liner material or margin material, depending on which material I'm using. And the purpose of that is I want to create my chroma, my value, and my fluorescence all on the inside of the case immediately. So that's kind of the first protocol for me. And I think the one thing I probably have talked about a lot for most of the people who are watching, my wash bake and your wash bake are two very different things. My wash bake is powders that I'm actually using to create the chroma and the value and the fluorescence that I want on my canvas. And then I'm going to fire that, and you should be able to see all the little detailing things that I want coming through in that material. I just took a few pictures of it with a little darker lighting so the colors pop out at you a little bit more. And that's where I'm going to get my basic for all the hue, value, and chroma that I'm looking for. And then the buildup will be very standard, my normal dentins and enamels. I'll start to get my shape and form. And here at this point is where I'm going to put some pink in. And I'll walk you through some of the pinks and how I start with that in the last case. But I'm going to tell you the pinks I'm going to start with at this point are usually going to be the most chromatic pinks, or the darkest ones that I have, and the most opacified pink materials that I have. And as I started working through it, I realized I got to start adding pink onto the cuspid a little bit, and maybe even a little bit onto the central to really start getting this to kind of work out the way I wanted it to. So I finalized the case. Dr. Miles actually went through his protocol. He cleaned it. Also takes all these great photographs. He's going to try that in the evaluation. And this is always a good sign, right? When I'm looking at the tissue and I'm looking at my tissue, and I'm like, all right, is this going to work? As he's sliding this in the patient's mouth, he's going to slide that in there. And what I want at this point is pressure on the tissue, but I also don't want to put too much pressure because I want to develop somewhat of the interproximal papillas. Hygienically, we have to make sure this is cleansable. So what does that mean? I want to put enough pressure on the tissue that I'm actually pushing up and it looks like it can kind of start to blend in, but also it has to have enough smoothness and roundness under the pontic so that we can thread floss through there and the patient can clean and floss inside and outside of the pontic site. So managing that hygiene is kind of a real critical spot for us. So the final case gets cemented, looks okay. I wouldn't say it's perfect, but looks pretty okay. The patient was happy, and you can see in her normal smile, you see the pink. And really the key here for us that we missed was, I said, adding some of the pink onto the cuspid, not to the central, I think is what we were kind of a little brain dead in the very beginning. And it took us a little while to catch on that that's where we really needed to be. So Katie's a happy camper. She smiles big. She feels comfortable. And we gave her back all the little details and things that she needed in the restorations, managing both the pink and the white. And there's a final. Now, as we go through our cases, they get more and more complicated. So I want to try to stay on time here. Big implant case. Now I'm dealing with full white and full pink. And again, this changes the game. Actually, more to my advantage, right? The Katie case I just showed you is more challenging. Why? It's basically a single central on a 3-unit bridge, a pontic site managing the tissue, high smile line, and really tiny amounts of tissue. Hardest thing we could do in dentistry across the board. This, not as difficult. Why? We have implant positions, but I get to control all of the pink. I'm going to build all of the pink. So my job is really not to worry about matching this pink so much. My job is utilizing the pink for my papillas and to support where the CEJ should be, or the gingival aspects should be for the restoration. So on all these big implant cases, if it's going to be a crown and bridge case like this particular case was, we made custom abutments. These abutments actually get seated into the mouth with jigs. So we make these little jigs so the doctors can transfer that to the mouth. This was an old school metal frame. I'm going to be honest and tell you, of course I do zirconia, pink cases, and lots of different materials for everything I do. But with some of the bigger implant cases, I'm still a fan of metal ceramics, even though they're expensive today. And the real reasoning behind that is because of what you see here. One, I can make my connectors smaller, and that means I get to have better strength in my connectors, higher flexible rates in the material itself, and less and more room to work for interproximal depth and embrasures and emergence profiles. So that's kind of a benefit for me. Doesn't mean I don't do them in zirconia. I do. This particular case was a metal ceramic case. Also, the other real reason that this was metal ceramic was one or two of the abutments, the angulation wasn't good, and I couldn't screw retain them. So I want this case to be retrievable. Retrievability is really king for me with implants. And to do that, we actually use something called a lingualized screw or a set screw. So we can make that abutment. I'll go back one photograph. One of these abutments here that you see, the angle was bad. So rather than try to figure out how to work through that or make it a soft abutment, I'm just going to make an abutment and I'm going to screw a hole right through it so I can actually set screw the case in rather than having to worry about screw that one in. So that's basically that little hole you see in the lingual of that number 7 tooth there. Okay, from there, we'll try the framing, we'll do all the normal verifications that we would normally do, and I'll go through my normal ceramic buildup. And again, I've been through this with you guys a lot of times. I usually start with opacious materials, either my CP materials or my EC materials, depending on which system I'm using. In this case would be VM13. So I would be in the CPs, which are my Chroma Plus materials, or the ECs, which are my FET Chroma materials. And at this point, I would not be putting any pink on. Believe it or not, I'm actually putting some more white materials up here by the cervical. So I'm using like a CP1 or an EC2, which is kind of a whitish, a B1, an A1. And the purpose of that is because the pink, I don't want to use pink opaques. The bone is not pink. I want to match the color of the bone, which is tends to be more on the A1, B1-ish color. So I'm actually going to use those materials around the cervical and then put my pink over it. Then I'll start going into my dentin buildup. Again, no pink at this point. This is all just opacious dentins. Then I'll start with some of my effect materials and shape it. And you'll notice even at this point, I have all my enamels done. I have everything kind of done, my full form, and I still really have not put any of the pink on in the restorative aspect. I'm going to save that. And the reason I save that is because I'd like to get that first bake done. And after that first bake is done, then I can come back and start finalizing the pink and finalizing my secondary shapes in the second bake. And then I'll usually finalize the pink in my correction bake or my glaze. So for me, in a case like this, I want to do in 2 bakes, one full bake with everything, one little correction bake and everything in my pink, and then I'll finalize the pink in the glaze bake. To do that, I have to trick the material a little bit. What I mean by that is I like to make the pink material lower fusing. So if I'm working with VM9 as an example, I'm going to use my pink powders, but I might mix in a little fusing material, either some glaze powder or correction materials. And the reason I'm doing that is because I want to fire the bridge in a lower temperature to glaze, but yet I want to make maturation and get translucency out of the ceramic itself. So I'm actually trying to create both aspects of it and do more of this in the paint. Sorry, it's a little noisy in my office today. So there is the glaze and final restoration. You can see the set screw from the lingual, and you'll notice here that the pink is glazed and shiny and translucent and all the little details that I wanted at it. And you can also notice that I have some lighter areas and darker areas, and I'll explain that more in the last case. But there's our final case. Shape, form, color, texture, all the little detail things that we want. And then we can basically place that in the patient's mouth. Sorry about the last pictures there. These are ring flash pictures, they're not mine, but you get the idea. Everything works. And did he need a ton of pink? No, he just needed enough to be supportive of the lip and to have pupillas where we need them to be to make the teeth look normal and define the parameters of the size of the tooth and the white and pink part of the tooth. So let's walk through one last case. I think we're just about on time here. And now let's dive into breaking down the actual pinks itself. This is Sean. Sean was a guy who wasn't involved in a bar fight, but I think he got hit with an elbow in a bar or something during a fight, and they knocked out his 2 front teeth and basically lost a lot of the bone. This was a perfect example because Sean actually had 3 bone surgeries and 2 implants placed, and the bone really never seemed to take as well as it should have. So in the end, this was going to be a white and pink case. I always like to preference this case by saying Sean was a reverse smile, And why is that important? We went back and got pictures of him years before the accident. We wanted to kind of judge where the insides of the ledge belong. And he was a reverse smile, which means the anterior foreteeth were up higher than the cuspids and the plane. And it was good to know that, because as we're going through the wax ups, our job is, our brain is sending to bring those teeth down, and they shouldn't be brought down. He was used to having them up higher. That's where they belong. That's where his phonetics are and his speech patterns and where his teeth have always been. So that made life a little bit easier for us. One of the tricks here that I think is a kind of a cool thing that we do a lot of with communication on these cases is, you notice the doctor has made his own shade guide. And we do this by using composites. So whatever ceramic you're using, like if it's VITA, for example, VITA has pink composites. The doctor can have those in the office. They can make and mix and match their own little shade guides, and we can send that off to the laboratory with the case, so we have a real reference of the colors that we're looking for, besides for the normal standard shade guides that we use. We're going to provisionalize the patient. I wound up making 2 metal abutments. So again, I'm going old school on this. This case is only about, I think, 2 or 3 years old now. Why metal abutments? A few reasons. One, I had to design the abutment to be as structurally supportive as possible, but also I knew I was going to want to set screw them because the angulation was bad. So the set screw works much better for me with the metal abutments or titanium abutments than anything else. Because we went metal abutments here with the set screw, I'm going to be making metal restorations. So the crown on the left, or the number 7, is going to be a full coverage metal ceramic crown with a ceramic margin. And on the number 10, it's going to be a ceramic feldspathic veneer. So we're pretty good there too. Okay. So ceramic margin, crown, and my 2 metal ceramic crowns. I'm going to start the build up again, very similar. My effect materials, either effect chroma or chroma plus material to get my basics. And you notice I didn't do much here. Why? Because I have gingival material here, and I'm just going to put a little bit of color here for the brightness of the tissue support in the same materials that I'm using for the rest of the build up. Then I'm going to start my dentin build up. I covered this with a little bit of a brighter dentin because I want to get that white and brightness underneath where the tissue is going to be. And then I'll go into my chroma dentins, my 1M1s or 1M2, whatever I was using to build this case. And once I get my build up kind of finalized and my mamelons are done and all the normal things that I'm kind of done with, then I'm going to start to come back and start thinking about what I want to do for that gingiva. So you'll notice here that now that I have the whole case kind of built up, I'm going to start working on the gingiva part of this case. And I can tell you that whenever I start working on the gingiva part of the case, my usually first inclination is to go with my higher chroma, my darker colors on the inside. So usually that's going to be a G4 for me. Depending on the person's complexion, sometimes I'll go to a G5, but usually I'm in the G4 range, which I feel like is a dark, warm kind of pinky salmon-y color, and that's what I really want more on the inside, and that's going to be all for my first bait. So I also have a pattern that I kind of follow with my materials, and I wanted to break that pattern down for you a little bit. Yes, the manufacturer provides us with colors, but it doesn't mean they're perfect. It means that they're kind of representations of what we think gingiva is. And when we look at the basic colors, G1, G2, G3, and G4, and G5, I'm going to tell you that the G5 usually only falls into much darker complexion people, and then everything else is kind of G4 forward. For me, I'm usually starting my sequence this way. Inside, I'm usually starting either with a G4 or a G5 to get my most amount of chroma on the internal aspect. After that, my second layer is going to be more of the G3s and the G2s, which is a little bit lighter in the pinks and the red. And then in my third layer, I'm going to be using all 3, the G1, 2, and 3, so all in the lighter colors. So I'm basically building in order, highest chroma, and then getting lighter and lighter as I go towards the side. And that's everything that I would put into that first bake that you just saw in that photo. So I started with the G4, and then I went back to adding a little G3, and then a little G2, and maybe even a little G1. So there's actually 3 or 4 different powders in that first bake. After my first bake, and after my shape and my form is all cleaned up, I want to come back and finish that in a correction bake. And now I'm definitely going to stay just in the G2s, G3s, and G4s. But one more thing that I'm going to do when we go back to this slide, you're going to notice that these last 2 mixtures that I have here, I've given you 2 different formulas. I have the G1, 2, 3. I'll use all three of them differently. And I might add in some translucent materials that either have chroma or are purely translucent. So I'm just basically making the material more translucent is all I'm really trying to do. And by the way, I can also do that by using correction material. If I put a little bit of a correction material into this mix right here now, then what I'm actually getting is a more translucent material that fires at a lower temperature. So that's kind of an easier way to manage the correction materials or the final glaze bake. The last section you see over here is basically the same things at G1, 2, 3s, and 4s. But in this case, I want to add a whiter translucent, something that gets a little more brightness or value to it, or a correction material that's a higher value, brighter correction material. So again, I want the translucency, but I'm using a scale of formula to increase the translucency. This way, when I get to my final bake or my glaze bake, all these powders that you're looking at now, they're the 1, 2s, and 3s. The only difference is they have all different translucents or effects in them. Now, I'm going to be honest and tell you that really what they are inside is all correction material. I use a correction 1, which is a very white, bright material, or a correction 2 or 3, which is more translucent and has a little bit of warmth or color in it. So that's kind of an easy way to manage through the system. But if you're uncomfortable with the correction materials or you want to do more of this in your earlier bakes, then you just go straight to your enamels and translucents. So I could use an NT, I could use a window, I could use EE1, a very white material. Any of them work mixed in with these three materials. So that's really my whole gingerol secret, is kind of mixing those things together. And you can see when I final glaze that, what we get is the final results. You can see the white and lightness where I want it, the dark and warmth where I need it, and the different, oh, I can't think of the word I'm trying to say, how it is not exactly the same from where it lies against the CEJ or where the tissue starts to get a little thicker and comes up and will be supportive for the lip. So there's our final case. One of the cool things is with zirconia is with the new Lumax materials, and this is kind of something that I've been pushing for a lot of years. If you're still using a VM9 or another material on zirconia, one of the beauties of the Lumax materials now is it fires at a lower temperature. So this kind of fits perfectly for me, right? Because I could finish the entire case and come back and low glaze the case and actually jump out of whatever system I use and use the low fusing gingerol materials to finish the case. So I've always said for years, if I was designing a new ceramic material, I'd want to keep the temperature slightly higher, but all the gingerol materials slightly lower. This way I have the ability to manage both. And this kit actually has a lot of cool colors. Matter of fact, I'm going to use it today on that veneer that I have to do a little gingerol add-on. So I'm hoping that's going to come good later on when I work through that case. What goes back to the doctor at this point is my jigs to make sure the abutments are good. My plungers, what are the plungers for? I don't like the way the doctors normally fill their cases with cement. So we send them these little plungers so they can put cement in, plunge it in and out, so it just gets a thin coping, a thin shell of it on the inside of the coping. We don't need a lot of cement because remember the crown's going to be held in through a set screw. So the window screw is going to really put what holds the case in, and then all this goes back to the doctor for the insertion. So we have a veneer, 2 metal abutments, a full coverage prep. You can see the lingual aspect of what it looks like, very tight on the occlusals. So we kept metal linguals, 3 restorations, and then a lingual set screw for the doctor to set screw that in at the end of the case. Here is the before, and we'll basically attach this all into the patient's mouth. I think the pink worked okay. You know, I could always argue that it could be a lot better, but also we had a little challenge because we had 3 separate restorations, right? So I kind of had to leave a little bit of spacing here for the patient to be able to floss and keep the hygiene part up of the case. But in the end, I think it worked. Those are how I kind of worked through all my pink cases in the end. And again, I don't want to make it just about building the pink. I think you have to be thinking of the face white and pink for every case you do and every aspect of every case you do. But yes, the build-up sequence becomes kind of simple, hopefully like all my other build-ups, right? Where I kind of create little systems and I make those systems kind of work for me based on the amount of space I have and final results for our patient.
I mean, they just look great. I'm super happy. Tell me about, the experience of having teeth again.
Oh my God, it's awesome. I'm sure as you noticed when I first walked in here, my front lip was kind of covering my teeth a little bit more than they are now. You just walk around with more confidence. It's pretty nice to not pop your teeth out before you eat any meal, so that's pretty nice. Like you go to a restaurant, you want to like bite into something, but hey, you've got the retainer, and not gonna pop this out, so you're like secretly doing it, and then you're very timid.
Or you have the temps and you're ready to take a break or something.
Exactly. Then you just get very timid and almost shy and self-conscious, but now I walk around and got all this confidence back. Nobody knows that they're fake. They look so good that people are like, oh wow, you have really nice teeth. I'm like, guess what? They're all fake.
Yeah.
So that's how we managed through the situation. I think I'm right on time there, Jen. How's that? All right, I timed it fairly perfectly. So with that said, I'll say thank you to you guys for popping in here today. Hopefully I addressed all the needs that you wanted, and maybe even diverted from a few of them, so it can kind of create some more thought process as you work through your cases. But thank you for coming in to the webinar, and hopefully there's a few questions you have for me. Thanks, Jim.
Yeah, thanks, Peter. Greatly appreciate it. That was a fantastic webinar. A lot of good information. I'd like to have everyone, if you have questions, we have quite a few already, but if you have further questions, go ahead and start sending those through. And we will just cover a few things here. So just a reminder that the video, the webinar itself, has been recorded and will be available in a couple days on our websites. So VITA North America, the YouTube channel. If you have CE, if you're looking for CE, you will get an email bounce from the education department asking you about a couple of follow-up questions so that we can get you the CE information. And then as I mentioned, we've got quite a few recordings. All of Peter's probably what, you've done a dozen so far this year or so or more. I mean, we've done so much.
Wow, right? So yeah.
Yeah. And we've got quite a few coming up. So those are all posted. All the previous ones are also posted on that on our website. If you need to get a hold of us internally at the VITA North America, that is the information that you can take a snapshot of and get a hold of us. And if you have follow-up questions with Peter, we can get a hold of Peter and have him help you out as well. If you're looking for your sales reps to find out more information about that Lumex AC or any other the VITA materials, please give your local rep a phone call. This is the information on the screen for all of those VITA North American reps. We finished today's webinar, but we've also got another 6, 7 scheduled for the rest of the year with Peter. So please join us again for another Pizzi webinar. We changed it up, right, Peter? As you mentioned earlier, I mean, we try to make these as a variety of them. We're not sticking to one theme. We do quite a few. I wrote a note down that maybe we could put something together, an occlusal lecture talking about that constrictive envelope of function. So if you have any recommendations, please get a hold of us and let us know, and we'll try to work that out with Peter if you're interested in anything else. So as far as questions go, let's start with one by Carol. Are you going to, so you did talk about the shade for dark and then trying to build it. If you're doing like an A1, it becomes A3.5 or A4. How can I solve to make it right as far as shade, moving it from one shade to the other? So she's got an example of if it's really dark, if the shade is really dark, if they're building an A1, it becomes A3.5. So how do you deal with the canvas? It goes back to some of the previous messages that you gave us.
Yeah, I'm not sure I completely understand the question, but I think what you're just saying is the transition from a darker prep to a lighter final restoration. If that's what the question is, the simple answer is you need about 0.2 millimeters per shade change. So that means that every shade change you go, it's about the depth of the restoration that you have. If you're doing veneers, very difficult to change shade in 5/6 of a millimeter. Sometimes you need almost a millimeter. And the other aspect is fluorescent materials. A lot of times you can get a lot more in a very small space by using fluorescent materials first. They tend to have a lot more light reflection and optics to them, and they tend to push the light in and out a little bit more. So a whiter, brighter fluorescent material over the base of your restoration, and then layering a normal layering afterwards will help you to get a little more light reflection, if that's what the question was. I'm not sure. And if it wasn't, Carol, I'm sorry, just email me and we'll go through it again if I missed your main point.
So another question is, do you control, it's going to obviously dependent on your frameworks, but the question is basically, do you use a slow cool, a cooling period to prevent the veneering ceramic from delamination? And then the second part of the question is, how many firings do you do before it starts to increase the lucite crystal formation?
Say that last part again, Jim.
As far as how many times do you fire your porcelain, and part of that question is because of lucite growth and diffusing your optical properties at that point.
Yeah, so to be honest with you, and I hate to say this because I think people misinterpret what it means sometimes. I've kind of become a one bake person. But one bake for me might take me 20, 30 minutes of a single crown to build up with 20 different powders. So it doesn't mean I just build up a block and then I grind it in. I'm building it in steps and sequences. I like the lesser amount of bakes for just the reasons you said. You create more lucite, more glass. The more you fire, the more translucencies you create. So the less amount of bakes with most ceramics, the better they can be. Obviously, when you get into larger cases, big bridges, big implant cases especially, where I have lots of ceramic space to work with, one bake is virtually impossible for me. And for most people, even with different materials, you still need to have, one good main bake where you put everything in and then kind of do a second bake or a third bake. So I try to limit my bigger cases to 2 bakes and a glaze, but I may sometimes do 2 bakes and 2 glazes, meaning that I'll do my main bake, I'll do a correction bake with a normal baking temperature, and then I'll start dropping my bakes down even more and do additive in the glazes. So this way I'm not kind of pushing the boundaries of the ceramic. Can you go 3, 4 bakes? Yes, you could. Should you? If you can avoid it, right? The less baking you can do, the better it is for the material. It's like anything else. You keep putting the bread back in the oven, it starts to get a little dry and chalky tasting at some point, right? So you really want to keep that ceramic baking to the 2 to 3 point, and then after that, the low fusing. That's why, by the way, I showed you the lower fusing my temperature of the ceramic and the pink to do that at the end. So I'm not trying to get the extra bake or 2 with pink material. I'm doing that more in my glaze bake, which is 5, 10, 15, 20 degrees lower than my first bakes.
So when you do the glaze bake, do you sometimes find that you need to augment or add more chroma or more red color through a glass stain at that point?
Yeah, sometimes I'll look at it and think, I want a little bit more whiter here. But there are times I'll fire that gingival bake and I won't even use gingival material. I'll just use maybe EE1 or something very white. And there are other times where I might take translucent material and add a dot of red stain into it or something to kind of just give me that little extra effect that I need based on the space, right? Because one of the bigger challenges, especially with pink materials, is the opacities of the materials aren't always as good as they should be. And the other problem is we don't have the same amount of space to work in. So because we have less space to work in, the material thought process is a little more challenging.
All right. So you had mentioned when you do a try-in, sort of a quasi try-in to check the tissue level for hygiene, and the question is, how do you judge how much pressure you have?
Yeah, it's a great point. So part of that has to do with the clinical version of that, the clinical side of that. You know, normally where the bone level is, the tissue level is about a 3 millimeter distance. So in a normal world, we have the ability to put about, you know, almost a millimeter or so of pressure on the tissue. And that's kind of the ideal scenario. But some patients don't have the normal biological distance. Sometimes they have a higher crest of bone, or they have a thinner type of tissue, which means it's a little closer. So for us as technicians to make the decision alone, sometimes it's challenging. Because if I want to create an ovate site and put some pressure on that tissue, and the doctor goes to do that in the mouth, and the tissue is only 1.5 millimeters thick, but then they're hitting right into the bone, right? And that changes the concept a little bit. So I think it's important that we're really kind of very aware of, you can go in. So I think it's really important that we're aware of the type of bone and tissue we're working with. The other aspect of that I would tell you is tissue is very resilient. So I could blanch the tissue. I actually have some interesting cases where I could show you where I purposely over blanch the tissue like crazy, right? And you put it at the crown and the tissue goes white. And within 2 to 3 minutes, you would think, oh my God, that's no good, it's too much. And all of a sudden that tissue starts to form and the color starts to come back. So there's two answers to your question. Tissue is resilient and you can do a lot of pushing and movement with it, but also you want to be very aware of where the bone is, because that will dictate what you really can and can't do.
All right, thanks. So many of your cases, you had some very natural looking stippling, if you will, tissue stippling. How do you create that?
Simple answer, toothbrush. I use a toothbrush. So after the ceramic is all done where I like it, right before I'm about to glaze it and the powder is just a little bit on the drier side, I grab a toothbrush and I kind of tap in a few areas and then just glaze it. So it's a little toothbrush trick.
And then let's see here. So on your lingualized screw, do you use a standard prosthetic screw from the implant supporting system, or do you use your own unique set screw?
So we use the Dentin set screws. Those are the ones we like. They're more taper screws, so that means the screw is thinner on the where the screw starts and gets thicker as it goes towards the head of the screw. So the more you turn it, the tighter it gets. It's a Morse taper concept, similar to an implant. We've been using the Dentin tap screws or set screws. They call them tap screws or long screws in Australia last year when I was there. They were all yelling at me saying, no, they're called long screws. We invented them. Everybody thinks they invented everything everywhere, but okay. We're using the Dentin 1.6. Very rarely we use the 1.4, it's smaller, and there are situations where we have used it, but we kind of prefer the 1.6 in the Dentin.
All right. And then do you, on your cases, do you recommend to use a provisional PMMA framework prior to the zirconia fabrication, like for an all-in-4 case? Do you use any provisional at all, temporary?
Yeah, of course. So I mean, especially if it's all on 4. You know, I had an all on 4 case I was going to put in, but I just thought it was a little tight on time to get into that too. So with all on 4 or all on 6 or whatever the case is, usually we're always making what we call a prototype, and that prototype is always made out of PMMA. Sometimes it's metal reinforced, sometimes it's just fiber reinforced. It really depends on the case. We like the metal reinforced ones where we actually cast the metal frame, opaque it, and inject PMMA over that, and then composite hand build the pinks. And the real purpose of having those is, God forbid anything goes wrong or breaks or final restorations, we have an issue, we always have a restoration to go back to for a repair or a change. So in the end, the answer is yes. We always create a prototype that becomes a standard for us.
All right, and then you showed several cases with implant abutments, and you masked the collar area with with porcelain, or did you use composite before you did the crown?
So the case I showed today was ceramic. It was ceramic margin material, and the technique for it is fairly easy. The only sensitivity to it is if I use a UCLA and I'm going to cast it, I'm going to cast the UCLA with ceramic metal, right? So the bottom line is now I can actually have the ceramic metal on the UCLA, and I could build ceramic right to it, no issues. Kind of a simple way to go. If I was using titanium to do that, I know VITA probably doesn't push it, but you can use the Lumex on titanium, so that's kind of a way to do it. Or the other option is there is amazing bonding materials that bond well to titanium and metals, and you can use composites to do it. So any of them is fine. For me, I tend to do them in ceramic because I kind of just like doing them with ceramic margin material.
All right, thanks. So this question has a little bit of information to it. So Elizabeth asks, my concern is the integumental portion of the pink for hygiene, whether it's convex versus concavity around the tissue area. How do you see follow-up? Do you see any tissue reconditioning and how's the cleaning? Do you have issues one versus the other, concavity versus convexity against that tissue?
No, so Elizabeth, that's a great question actually, and that's probably the most important. I tried to touch on it a little bit in the hygienic part. When you're dealing with implant restorative that we're cementing or screw retaining, it's a little easier to manage. But when you're dealing with the all-on-4, all-on-6 concept, what really is the challenge is two parts. One, you want smoothness in the material, right? So the goal is your pontic, which should be convex, should be smooth like glass. And that's another reason that I like to use lower firing materials there, right? Because I really want to create that really glass-like matrix in the material so it doesn't attract any of the plaque. The other challenge is, where is the aesthetic zone? And where it's kind of misdiagnosed on the clinical side is when I see a patient smile and I determine where the incisal ledge belongs, that also helps me determine where the bone should be. And what I mean by that is there were a lot of times I look at a case and say, here's where we want the incisal edge. I only have 10.5, 11 millimeters to the bone, but I need pink anyway to support it. Rather than work from that area, I would rather the surgeon took away more bone. This way I can hide the transition and keep the emergence profile more balanced in the final restoration. So there's kind of twofold there, Elizabeth. One, it's working closer with the clinicians and the surgeons to manage the aesthetic parameters of where you want the bone and tissue to be. And then the second part is on our end, creating more convex, smoother transition periods where you can flush thread through there and still be able to clean out in the sites. What you don't want in the end is the ridge laps. That's where the problems come in. The minute you start ridge lapping, not much you can do to keep it healthy and clean. And by the way,
right.
For that,
yeah,
acrylics tend to be much worse. So if you're doing all-on-4s, all-on-6s, and you're using denture teeth, Toronto style bridges, titanium bars with pink and white acrylics, 3 months down the road, they look bad if you didn't manage the intaglio surfaces. So this is another reason that, I kind of like managing the cases through Crown and Bridge if I can, although they're much more expensive to manage that way.
All right, well, Emad wants to remind us all that, yes, Australia did invent those set screws, those single eye set screws. So,
what was your name?
Emad, E-M-A-D, and then last name Marty. M-A-R-D-I-I.
I've had the luxury of traveling the whole world, and everywhere I go, it seems like everybody's invented something. So it may be completely true. I have no idea. I can tell you I've been to about 15 labs over the world that all told me they invented veneers. One of them's not telling the truth. I'm not sure which, but whoever invented it, hat tip to them because it's a great technique.
I thought that was originally called the Renaissance crown.
See what I mean? There's always another version.
So the transition line between your tooth color and pink color, do you brush that in? Do you create it using a burr? How do you actually create your cervical junction?
Yeah, so I do it a few ways. So one, first off, that material, that pink, realize the white is done and kind of set and finished already at that point. So when I'm putting the pink ceramic on it, I can actually have a little more control. I put a little bit of glaze medium in my pink ceramic to change the viscosity of the material so it's a little bit thicker. And what I tend to do is I'll build that right around the cervical area, and believe it or not, I'll take my brush, I'll snap it to get a really nice point, and I might come in from the incisal edge down and kind of just create a little bit of a final line where I want to. But I could do that because it's very thin, and I've added a little bit of glazing medium into the powder to give it a little viscosity.
All right, nice. So if anybody has further questions, please send them in. And then this last question, otherwise the last question, Robert is asking a webinar using feldspathic to build up ceramic. So maybe like a VITA block or other machinables, and using Lumex. So I think we've done that before, but we can certainly add that on as well. So we've got plenty of topics, right? All right, Peter, anything else? Any last words, parting words you'd like to say, let everyone know?
Kudos to you. Thank you. You know, I have to be honest and tell you, when you and I talked about all these different webinars, and you kind of threw a bunch of, you were helpful and threw a lot of the topics that you were getting information back. It's kind of a fun challenge, right? When I open up the topic and I see what you have promoted, and I got to go back and fill it. And it's kind of a different approach for me. So it's kind of fun, to be honest with you. So thanks for the topic choices. And I hope I'm living up to your concepts of what you wanted them to be.
Oh yeah, no, the concepts, your presentations have been great. We've got a great audience out there. They participate. They watch all of your webinars. There's just a sample of some of the past ones that we've done in the past, and then remind everyone that Peter, we've got plenty of more webinars to come along this last half of the year. So please join us again. And if anything else, we will say goodbye to everyone. We'll end this webinar. So thank you very much, everyone, for joining Peter Pizzi today on this VITA Learning webinar. Thank you very much, Peter.
Take care, Jim. Talk to you soon.
Okay. Bye.